is Joyce Graff. I'm with The Powerful Patient. We have with us this morning Michael Millinson, who is a consultant with a practice called Health Quality Advisors and works with people around the country and around the world in trying to improve the quality of healthcare for individuals. And so welcome, Mr. Millinson.
Thank you, Michael, and I'm happy to be here.
Great. So, Michael, tell us a little bit about how you got into the issue of participatory medicine. We were interested to read your article recently about, does a pandemic preempt participatory medicine? So, a very intriguing article. And tell us how you got into this idea of participatory medicine in the first place.
Well, I was a reporter for the Chicago Tribune for a long time, writing about healthcare. And I finally got to a point where kind of I knew too much and really wanted to go out and show what was happening. And I wrote a book in 1997 called Demanding Medical Excellence, Doctors and Accountability in the Information Age. And it really radicalized me. It was about evidence-based medicine, quality of care, patient safety, patient empowerment. And you could see how many years patients had been asking for their voice to be heard, and it wasn't heard, literally since the beginning of the 20th century, through the feminist movement, Our Bodies, Ourselves, the AIDS patients who were the first to really persuade doctors that we are as expert in our disease as you are. We have different kinds of expertise, and so on. So I became very kind of cognizant of some of the imbalance of power. And eventually, after I finished my book, and I knew I was working also in e-health and what the internet could do to change that, I came across the Society for Participatory Medicine and became an active member. And really for me, medical decision-making, the patient's voice are all very important because although I am a healthcare expert and have an adjunct appointment at a medical school and write for the literature and do research, I am at heart a patient activist. I mean, that's how I get into this. And when I wrote my book, there's lots of academic stuff that goes on, but when I wrote my book, the bottom line was, I'm not going to write about anything that doesn't actually affect patients' lives. And that's what I care about.
Great. Yes, and we care very much about quality of life as well. Robin and I both work with a number of people with complex medical conditions and disabilities. And sometimes it's hard getting the attention of the physicians to listen to your voice. And if you really hit a brick wall there, we advise people to find a different physician. But we really love to create partnership with our doctors because we need their expertise. And they also, by the way, need our expertise because after all, we live with our bodies 24 hours a day. So we have a certain expertise in what this particular organism is about.
Absolutely. And one of the joys of sort of getting into this area is you do discover some extraordinary physicians who are pushing for change. Sometimes, the culture of medicine is not easy to push from without or to push from within. It can be pretty hierarchical and pretty difficult, but there are some extraordinary things being done, particularly with complex diseases, but also in general medical decision-making. So we are making progress slowly, but when you look at what we could be doing and what we should be doing, and what we are doing, it can be a bit frustrating.
Right, and let's start with COVID because here we have a situation where we're all learning about COVID. The doctors are learning about COVID bit by bit as well through this year. We know a lot more now than we knew a year ago. That's true for the doctors as much as it is for anyone. But the people that we work with start out with a complex medical condition. They already have certain warning signs that they're keeping an eye on. And now you've got all these COVID things to worry about too. I know one patient that's close to me said last March, I feel like this virus is out to kill me. So got these concerns to add on top of it. But that also complexifies the decision-making from the doctor's perspective. So it does all get woven together. There must be some circumstance that inspired you in particular to write this article.
So, well, yeah, that's a good point, Joyce. And So I'm all in favor of patient empowerment, but I'm also in favor of realism. And so kind of my ideological preference is to be a militant moderate, right? And so are you the CEO of your care? Sometimes, but sometimes you're not. I mean, to me, the ideal is that you're in a relationship with your physician that is attuned to, as a couple of medical ethicists I like to quote talked about, the evidence, the doctor's experience, and your preferences and values. So those are three elements. And sometimes if you're flat on your back and in pain, you are not co-CEO of your care. I'm sorry. You need someone to care for you. On the other hand, when you have some of the complex illnesses that you're talking about, the physician needs to know what you're feeling, what your preferences, what you want to do. And then there's the evidence, which everybody needs to consider. Now, when it comes to COVID, and that's a great example, here you have not a lot of evidence out there, right? You have doctors at sea as much as patients, and then you have complex medical conditions. What do? Well, you listen and you have a little bit of humility, right? And I think that what I'd love us to learn from COVID, which hopefully we will at some point as some of the immediate difficulties pass, is the need for that kind of partnership, right? I interviewed a couple of long COVID patients, women, 30s, early 40s, at health plans that are renowned for being good listeners and all the rest, and they still weren't listened to, and they still were treated poorly. And I said, were the women doctors any better than the male doctors? And both of these women said, well, they had nicer bedside manners when they didn't listen to you. And so, people say, well, women doctors will be better and young doctors will be better. And, well, guess what? We're of an age where we remember like all those revolts of the 60s and 70s. And it turned out when those young people from, 1966 and 1968 got to be old middle-aged doctors, they were not that much better than the people who'd been old middle-aged doctors 40 years before, right? So we have to change the culture and have a partnership and have a listening. And by the way, have a way to capture patient symptoms systematically, what they call patient-reported outcomes measures. Because, we need that. We need that kind of systematic data. And it's coming. It's coming. Thanks to the internet, thanks to some culture changes, thanks to a lot of things. It's coming, but it is coming slowly. This is not a revolution that's going to end with a flag being planted on the Bastille. It's a very slow revolution.
Yes. And Robin, I wanted to give you a chance to say something along this line too. Robin is the lead moderator for smartpatients.com. So she talks to a lot of people with complex medical conditions. And I know you've heard war stories through this past year.
Yes, definitely. It's interesting. One of the things that we're hearing is now with the long COVID patients, the myalgic encephalomyelitis people who have chronic fatigue syndrome are really excited because they said now there are getting to be more of us, and doctors are seeing there's a real reason for this and it's a real condition, and maybe we'll get more attention. The rare diseases have a real problem in not being able to be diagnosed properly or promptly, fighting with doctors to get the attention that they need, fighting to be heard, and fighting to have doctors who are willing to work with them instead of saying, you're a difficult patient, go away.
Yeah, that's absolutely true. And particularly when there are economic pressures to see as many people as possible. One of the things I've learned from doing this for a while is a physician who's like a third generation family physician wisely wrote that doctors are like everyone else. And that's perhaps the greatest piece of wisdom, is that when you're weak and when you're vulnerable, you want a hero. Well, it turns out that 50% of doctors are average. Not all of them are good listeners. Some of them are extraordinary listeners. Some of them had a bad day at the office. Some of them love a mystery. Some of them just want to process you. And it's really difficult to find the right person. And, and this is where I sort of think the people who simplify this as consumerism are ridiculous. When you are sick, when you were in pain, when you were vulnerable, you are not a shopper. You are an individual in pain, and you're not shopping very well, right? And so it's difficult, and that's why patient support groups are so important. I had some worries about being this age about prostate issues, right? And I talked to my doctor, and I got a referral to a physician. My doctor knows that I'm a questioning person who is okay. But then I talked to a friend who was a former journalist who's really had prostate issues, cancer and everything. And he talked about another doctor in the same practice, in the same group, who was very different, both in his level of scientific knowledge and how he spoke to patients. And I went to see him, completely different experience, right? Completely different experience. Two doctors, same group, both smart, completely different level of experience. How do you find one or the other, right? And it's difficult, and that's where patient knowledge comes in, because when your doctor goes to see another doctor, they know it, they're treating a doctor. And their experience as having a dialogue with another doctor may be a tad different than those of us who go in without an MD. And so it's not cut and dry, but you're right. COVID, for people who have those other kinds of conditions, well, is this real, has all of a sudden raised consciousness that, you know what, this is real. And I used to talk to chronic fatigue syndrome patients, right? The same thing. Is this real? Especially for long COVID, and for these same young people, often women, often who are very physically fit, and they get pushed off. So yeah, that is a silver lining, as it were, that you've mentioned.
Right. I mean, there's comfort in numbers. So when you have more
Right.
people with chronic fatigue syndrome, whatever its cause, then at least there's more attention on, wow, this is maybe a real problem. It's not just they're malingering or they're lazy or go buy a hat. You need an emotional boost,
Well, let me interrupt you. That one of the long COVID patients I spoke to, she spoke to a specialist who said, maybe you should take out your IUD. And she's like, what is this, the 1950s? I mean, just outrageous.
Yes. So just gaining credibility is a problem. And as you mentioned, women tend to have less credibility when they walk in the room. People who are not dressed nicely, or people who are a little frazzled because they had 3 kids to get off to school before they came to this appointment, whatever. Those kinds of things will lower the credibility of the patient. And so we need to be aware of the things that we can do to try to improve our credibility, but also working with the doctor and respecting the pressures that they're under and trying to come to a meeting of the minds.
I think that's exactly right. And one of the things is to prepare what you're going to say, right? The literature says the doctor will interrupt you after 23 seconds, which is up from 19 seconds. So it's really some progress. And they're trained to be problem solvers. And so you need to be aware that, long monologues ain't going to make it. Help them be a problem solver. It's nice if they were going to be your kindly grandmother, but don't go in there and have that expectation. They're under time pressures. They have certain training, right? And particularly for rare diseases, they've all been told, when you hear hoofbeats, think horse and not zebra, right? That's the cliche. So how do you let them know that you might be a zebra without coming across as a hypochondriac, right? My headache is a brain tumor. Yours needs Tylenol. That's not so great. But sometimes you're like, Now, I will say that sometimes on the other end, that I'm very aware of, is particularly in groups, they have a tendency just to refer out, right? Okay, go see a specialist. Like, I don't want to see a specialist. My life is busy too. You're an internist. Can we just deal with this here? But sometimes they refer out too quickly, and then specialists have their own biases. So there's both not being listened to enough and being listened to too much, as it were.
Right. I completely understand that. But I'll tell you, one of the scarier stories that I heard around COVID was that I had a friend who came down with symptoms that seemed very much like COVID. She did go to the hospital. They kept saying, "Oh, it's got to be COVID," and yet twice she tested negative for COVID. And her family kept saying, but she was just up in the woods in Pennsylvania opening their cabin for the season, and there were mouse droppings all over the place, and there were mold all over the place. She was cleaning it up. Couldn't this just be an ordinary kind of infection thing? And the doctors were going, "Oh, it has to be COVID."
Wow.
Finally, they did get the doctors to do the testing, and 3 days later, the pathology came back. It was a more ordinary infection. They gave her antibiotics, and she finally started to get better. But for a while, she was in the ICU. She was fading, and we couldn't get the doctors to do that normal kind of pathology test. So I think there is a danger that you only see the things you normally see. You
Well,
don't look outside that box. And this year, the box was COVID.
that's fascinating. They call that anchoring, right? In that 23 seconds, they decide what you have, and all the rest of the evidence goes into that anchoring that I was right, which is okay if you're watching cable TV, but not so good if you're a physician.
That's
We
right.
have another common
I'm sorry, Robin, go ahead.
Another common situation is a patient's done an amount of reading on something,
Right.
and they themselves become convinced that I have XYZ.
Right.
And they go in and tell the doctor, "I think I have XYZ." You are poisoning the doctor's mind to become anchored in that, and rather than giving the doctor a free hand. So we tell people, don't say that at the outset. Describe your symptoms, see what the doctor has to say. Then if he doesn't mention XYZ, you can say, "Well, could it be XYZ?" And that's a much better way to introduce your suspicions.
That is great advice. That is really great advice, because first of all, self-diagnosis is going to maybe not be perceived so well. Second of all, it does anchor, and you can hurt yourself. So I think that's terrific advice. I know that when I have gone deep into the medical literature, because I have access to that, my going deep into the medical literature can sometimes be helpful, but often I do not understand the context of what I'm reading, right? And so, I'm reading a medical journal, I'm reading something deep, but you really don't understand necessarily the context about that. So yes, you can help a doctor who's not that good reach a conclusion that maybe he missed, but you can also throw people off and convince yourself you have something you don't. So I think that's terrific advice. And that really goes to being a partner, to having a dialogue. I think that's really what you want. You want a dialogue. If you think this is X, why do you think that? And on the overdiagnosis, you go, okay, you want me to get this test. How is this going to change what you do? Right? I hurt my elbow. I really don't need an MRI. I don't really need X-ray. You know what it is. You've seen 1,000 of these. Just give me the cortisone shot. And then if it doesn't get better, we can go get a diagnostic test. So there's a tendency to order the test, not just CYA. They're sort of incented to do it financially, and patients, they think, like it. And, I don't really get that excited about having a diagnostic test. A needle or a scan does not make me feel as if that made my day. So, be a wise consumer in this case, asking questions. How is this going to change what you do? Right.
Right. Another thing that came up for us all in COVID this year was that we were not as free to go to the doctor in the hospital and
Right.
get all those tests as we normally would, both for our own self-preservation and also because the doctors in the hospitals are so terribly busy. But tell me what you know about the use of wearable electronics now that will help you monitor some of those things.
Right.
Do a sort of self-test at home, if you will, and give you and your doctor some data that would be more helpful.
So the wearable, it's both the wearable and then also there's sensors in your home, which are not wearable, right?
Right.
This is a really important development, but it comes with a bit of an asterisk, right? Is that not all wearables are created equal. Not all sensors are created equal. Not all algorithms are created equal. So when it comes to COVID, for instance, there's been a lot of testing of whether these wearables can be an indicator of whether you have COVID. And so that's a really good thing, considering we have a highly infectious, deadly disease. When it comes to other conditions, sometimes the testing has been really good. There's Propeller Health, that was originally Asmopolis, with a sensor to tell you if you have asthma, whether you're moving into an area where the air pollution is bad or you've had problems before, should you take some sort of medication. So there's some really good ones that are getting careful FDA approval. And then when you get your Apple Watch or whatever, even though the small type says, not for medical purposes or something, we use that. Yeah, they're okay, but they're not as good necessarily as you think. Your Fitbit and a lot of other things you need to use with caution. There's a literature that talks about, I've talked to some of the people who've done these kind of tests about how good the sensors are, how good the measurement is. And not only does it vary, not only does it vary with an individual app or product between products, but do you have the Fitbit 5? Do you have the Fitbit 10? Do you have the Apple 13? Right? And so all of a sudden when somebody says, well, the Apple Watch is really good. Well, maybe that model is. Which model did you buy? And people can't tell. I did a study with some colleagues, and we looked at direct-to-consumer diagnostic devices. And quite frankly, the studies sometimes don't even name the model. Well, what good does that do you, right?
Right.
What good does it do you to tell you that a Ford is a good car? Which Ford are we talking about here? You should drive an SUV. Which SUV, right? And so the devil is in the details. So these are really good in a lot of ways and are going to be extraordinarily helpful, but be careful. And is it your doctor prescribing it? Is it FDA, right? Just be careful, because the devil is in the details.
Right. So they're indicators, but they're not official medical tests. And so they might give you a clue, but then you do need to confirm that with your doctor with the real medical test.
Right.
And if, for example, you can't breathe, but your watch says you're fine, which are you going to believe?
Well, that's exactly right. Well, but that also goes to with COVID, you have a pulse oximeter. How good is it? Right. And then it turned out with COVID, we found out that your oximeter could be saying that you're okay, but you can't breathe because it's affecting you in other ways. So yeah, you have to listen to your body without being panicky, and put things into perspective. You're absolutely right.
Great, thank you. You touched on open notes and access to records before also, and I'm in Massachusetts. I have the privilege of being with hospitals that have been amongst the leaders in providing open notes, and I think it's really important to read those notes, because this is what the doctor said about you that's going to be passed to the next doctor, and you want to make sure it's correct. And if you disagree with it, now's the time to speak up and say, there's a mistake in here. Could you fix this for me?
Absolutely. And it's even more important because although you have this right to get an electronic summary of your patient visit after you saw the doctor, at least the ones that come out from Epic are essentially worthless. They summarize everything else. They don't even include a diagnosis, for God's sakes. They just summarize everything. You saw the doctor, he said you have whatever. They don't even necessarily say that. They just sort of say prescribed whatever. They're worthless, except as a regulatory thing. And of course, there's no patient pressure group to say this is worthless, change it. There's no patient advocacy group that is embarrassing Epic or is embarrassing physicians. It's just, okay, we hand it to people. People are happy. They saw the doctor. They got a piece of paper, placebo effect. Open Notes is exactly the opposite. It's, we're in a partnership. Here's what we said. Here's what's there. I mean, one time I requested a copy of my electronic medical record, and there were some drugs or other things that were outdated. And I finally got the doctor on the phone, and they can, they sometimes can't even change things, right? It's well, it said you had it then. I mean, so while electronic medical records are really good, they also make it really easy for mistakes to be passed on. And we
Right,
have to be careful with
which
that.
is one of the reasons, and I think one of the benefits that I've seen in the reports from the early open notes testing is that the doctors realize the advantage of having the patient double check them, because there are mistakes that are sometimes introduced, and
Absolutely.
the patient's most likely to pick up on that.
Absolutely. And now, but there's a flip side here, right? For patients, for a lot of patients who are not perhaps as empowered and veterans as you are, they are now getting more responsibility along with more freedom, as it were, with more information. And there's going to be an expectation that you as a patient take more responsibility. So the flip side of paternalism is freedom brings accountability, freedom brings responsibility. And it's going to be interesting. How do people deal with that? How are we going to help people deal with that? Right. And it's not going to be easy. It's going to be messy like it is with anything else. And we'll see. So, did you not look at your sensor? The sensor's accurate, right? Did you not call your doctor? Well, maybe it's your fault, right? And so we're going to have to navigate new boundaries of partnership, and inevitably, because people are different, that's going to be messy.
Yes, I'm sure that's true. I think what comes to mind is some people I know with von Hippel-Lindau disease that causes a series of tumors. And if they go back and read the radiologist report, they sometimes will see something that their doctor didn't mention. Oh, you have a 1 centimeter tumor on the kidney, which is not a case for operating in the case of VHL, but it is something that the patient should be aware of. And the fact that her doctor didn't mention it to her was really shocking to her. So, yeah, I think it's very important for us to read those things. We're going to obviously absorb that at different levels of understanding, but it can open a conversation with your doctor that maybe he forgot to have with you. Doctors are human too, as you mentioned before. And so working with that doctor as a partner and not as a contestant in some other environment is really much more productive.
I agree. And it's going to change. Information changes relationships, no question about it. And that's what's going to happen here.
One thing we talked about earlier is how important it is to understand a little bit about how doctors think. You were talking about scan results. A lot of times the radiologist has written the report saying, incidentally, there's such and such. And the doctor may only read the summary at the end, rather than going through all 3 or 6 pages of the scan report to see every little thing that was seen. And so if a patient knows that, the patient will be more ready to get the report and read every word of it, because they realize their doctor might not have. And they might spot that thing that says, oh, incidentally, there's something that should be checked.
Well, that's a good point, Rose. That goes to you work with an organization called Smart Patients, and that goes to exactly that. Now, how do we not overwhelm doctors with 100 patients each saying, well, what about such and such? And it's not, doesn't mean anything, right? So there's that as well. So we're going to have to set up explanations, right? I mean, you give people lab results, tell them what it means, what's normal, what's not, right? Frankly, the way that information is communicated is even when they're giving you context, it's often very difficult to understand. Some organizations have worked very hard about that, like Kaiser, but often they just sort of feel if they give you, a chart that says if it's less than 0.3, it's within the range. Well, am I 0.28? Do I care? Right? I mean, right? And so they don't give you context. And that's going to have to be, we're going to have information with context, or else we're going to overwhelm people with, well, what does it mean? What does it mean? And just going to Dr. Google for context sometimes is not the best way to learn what's going on.
Right. I remember I once was with an 8-year-old dog at the veterinarian, and they did a complete blood count, and out came this sort of ticker tape display that said, this is a geriatric female dog, and for her normal is this particular range, and had a little chart, and she's here, and put exactly where she was on that chart. And I thought, this is brilliant. I've never seen one of these for a human being. I think this is a really nice way to display it.
So another thing patients need to know and need to learn from their doctor, and often have not learned from their doctor, is the units that their test result comes back in. Just saying my reading was 17 is not helpful. And a lot of patients do that. And they don't understand it was 17 grams per deciliter. It was, some crazy number that was way high. And the normal is 1.7, and I've got 17. They don't realize the importance of range. They don't realize the importance of units. They don't realize the importance of the exact name of the test. And then we also have patients who go in and know that I need my free TH3 tested, my free T3 tested. And the doctor isn't going to do that unless I really push him. So you have a whole range of patients with a whole range of knowledge going in to see doctors who have a whole range of concerns and a whole range of time availability. It's really hard to give one size fits all advice to anyone.
Well, that's exactly right. And I think that again is very important, that things vary. That's why I talk about doctors' experience, patients' preferences, values, and the evidence. And that's how it all interacts. And it has to be a relationship. But remember, doctors have a lot of patients. Do they know who you are? Are you seeing a doctor who knows you or not? Well, it could be a group where they just rotate. Does the doctor know who you are? Do you know anything about the doctor other than that you go, oh, they got out of school 5 years ago. Oh, they got out of school 20 years ago, right? I mean, what do you know about them? What do they know about you? And that's also why it's very important, if you have something serious, to bring somebody with you who can listen and is more objective. It's very, very difficult when you're really worried to listen. Get in the questions you need to get in. Even more so when you go to the hospital, right? That's why COVID's been so dangerous and difficult, because you can't have someone go to the hospital with you. And even people who are physicians and health services researchers and patient advocates and all the rest, they go into a hospital and stuff happens. And you need somebody around, because no matter how sophisticated you are, stuff can happen. And you have to speak up, and you have to have someone else speaking up. It's just the way it is.
Right. And if you have something serious wrong, like you only have one kidney, you need to tell every person along the way, I only have one kidney. You cannot assume that the last person told the next person. You cannot assume that your doctor remembers it. You can't assume anything.
I have a colleague who went to the hospital for a relatively routine procedure, health services researcher, but it was something because of his condition that was being done in a different way. And he's in there, and the resident, whatever, comes, says, well, you're having blah, blah, blah. And he goes, no, I'm having a different way. And said, no, you're not. This is how we do it here. And only because, right, he's a PhD and insistent and whatever, they listened and they said, oh, you're right. But the resident insisted on calling his doctor, which you understand, and say, oh, they put it down wrong. So they put it down wrong. Now, if you were older English was not your first language, scared, right? Would you have caught that? And that's the kind of thing that one of my pet peeves or pet projects is we need for hospitals to be high reliability organizations. Rose, when you bring up, well, you can't count on someone telling someone else that, right? Do you think in a nuclear submarine that there's not procedures for hands-off of what's happening off, where they make sure that everybody tells everybody all the relevant facts, or in an aircraft carrier, but on a nuclear power plant, when they change shifts, does the guy go, you know what, I don't know, there might've been some problems, but anyway, good luck, I'm going home, right? That's not how it works, right? But in medicine, we sort of have these sort of handoffs that are, well, okay, and maybe you look at the medical record and things like that. I was once at a conference where was the most amazing conference I ever went to on patient safety. There were people from all over the world and different occupations, including a captain of an aircraft, right? An airline captain. And he said in airlines, there's a saying that the pilot's the first one at the scene of the accident, right? And that's kind of what we need with healthcare, is that, okay, when you guys were worried about getting COVID, there was one kind of precaution. When you're worried about transmissible infections that are just, from the doctor to the patient or whatever, not as much worry, right? So we need to have high reliability organizations so that, we're talking about patient empowerment. If you go into the hospital and you're old and you don't speak English and you're timid and you're sick and all the rest, you're just as safe as the PhD in health services research, who's also an MD spouse, goes into the hospital. I want you to be as safe no matter what, just like in other industries. So I think it's really important that, yes, patient empowerment is important, but there's other things you should not be. For me to tell you to wash your hands is not empowerment. That's me being a fail-safe system, which it shouldn't be me to be the fail-safe system. For me to have a discussion about whether this catheter belongs is absurd. My 10 years as a real estate agent, I think you should take it out of mom. No, you should be having guidelines about when does it go in and when does it go out, right? Empowerment means legitimately on the things I'm an expert on and legitimately the things you're an expert on. And we kind of need to have discussions. And that's what real empowerment is. Keeping me safe is not an empowerment issue. Keeping me safe is the minimum issue, right? I don't get on an airplane and go, I wonder if any of the passengers are pilots too. Maybe we can talk to the guy up there, right? That's not a discussion that we need to have. And so safety is the minimum. Listening is the minimum. After that, it's a negotiated kind of thing.
Great. Well, thank you so much, Michael. It's been a delight to chat with you. We could talk with you all day, I'm sure, but just want to thank you very much for coming and talking with us, and thank you for your work and making sure that the doctors understand the importance of participatory medicine. We're working with the patients for them to learn to be good partners in participatory medicine, and we agree with you completely that this is the most important thing that we all can do, is to work together to make healthcare as safe and competent as possible.
Absolutely. Thank you for having me. And what you're doing with patients is so needed, so important, particularly for people who are vulnerable, people who have complex conditions. They're not going to get that anywhere else. So I'm delighted you had me on your podcast. And if anything we said today can help any individual be treated better by the system, be safer, get the care they need, that's just a wonderful thing.
Thank you. Thank you very much. Thank you, Robin, for being with us. And
Always
thank
a pleasure.
everybody for coming and joining and listening in today. We wish you all the best. Be well and be a powerful patient. Thank you. Take good care.